This webinar is a kind of a follow-up of the last month's webinar on methamphetamine. This time we will look into what is the available evidence and what is the current practices. I will give the floor immediately to ECR Indave, our colleague who will chair this webinar. Thank you, ECR.
Thank you, Marika. So thank you all for being present, for being interested in this topic. I'm very positively surprised how many people are showing interest in this topic. And for me, it's a pleasure to chair a webinar on methamphetamine use disorder, stimulant use disorder, and possible responses. I think the last webinar, we already showed that this is an important topic and that we have to have a look at it. We had contributions pointing towards the profound roots of this problem in the European reality. And I think we also were able to prove how there was an epidemiological background that points towards a possible increase that we have to look at. And in that sense, today it would be very nice to complement this information with our chairs and our guests. And I would like to give them the opportunity to introduce themselves, showing where they come from and what they will present. So first of all, I would like to invite Vittor Tardelli to introduce himself and tell us a bit about what he's doing and what he will be presenting.
Hello, my name is Vittor Tardelli. I am soon to be appointed assistant professor at the University of Toronto. I'm also affiliated to Universidade Federal de São Paulo in São Paulo, Brazil. And my current research interests include the treatment of stimulant use disorder, both cocaine or methamphetamine, and the epidemiology of drug-related events. And today I'll be talking a little bit about a systematic review with meta-analysis we published a couple of years ago on how prescription psychostimulants can be useful for the treatment of cocaine and methamphetamine use disorders. So thank you all for being here today.
Thank you, Vittor. That's very, very interesting and will be great. After you, we will have a contribution from Lars. Lars will talk a bit about the Atlas for Dependence project. Could you please introduce yourself?
Yes, thanks. My name is Lars Badness. I'm a professor at Department of Global Public Health and Primary Care at University of Bergen in Norway, and also a research group leader for Bergen addiction research at Haukeland University Hospital. And I have a background as medical doctor and a specialist in general practice, and I've been working with behavioral factors and substance use in particular. I'm looking forward for this webinar. Thanks.
Sorry. After Lars, we will have two distinguished speakers telling us a bit about the reality in Czechia. So that will be Roman Gabrelic and Jakub Minaric. Would you please introduce you?
Well, thank you for being here. We are very much happy to talk about our experience from the Czech Republic. I'm a full professor of health psychology and addiction sciences at the first faculty of medicine at the Charles University, and general teaching hospital in Prague, which it's a long affiliation. Our both mutual interest is in pharmacotherapy and methamphetamine in general, and people who have problems with methamphetamine use. And we will be talking about our experience, treatment experience in the Czech Republic, but also we will briefly introduce or discuss outcomes of our case series that we conducted with methylphenidate that was given to our patients. And I'll give word to Jakub.
I'm Jakub Minařík. I'm psychiatrist and I work 25 years with drug users, and I work with methamphetamine users and comorbidities with these people.
with the most severe ones, dependency. So he's really the right person to talk to. Thank you.
Thank you both. Yes, so and the final contribution will be from Dr. Jean-Ramon VLB, who will a bit talk about how to translate or integrate all this into a proposal for practice. Would you please introduce yourself?
Thank you, Itziar, and thank you all. I'm very happy to be here with you. I'm Joan Villalbi. I'm a physician. I'm a public health professional also, and I've worked for many years in public health and primary health care, and in the addiction field, essentially putting together programs and evaluating them. And for the last 2.5 years, I've been working as responsible for the national delegation for the National Plan on Drugs in the Ministry of Health in Spain.
Thank you very much. So then we may start sharing the presentation, and we can try to do together this work through the evidence and later on the examples going to a proposal into practice. So the first question would be, what do systematic reviews say about the current evidence on treatment of stimulant use, particularly agonist treatment? And Vitor Tardelli, the floor is you. We can't hear you. I think you're muted.
Okay, sorry about that.
Don't worry.
Okay, so we're going to talk a little bit today about the current state of agonist-based treatment for stimulants. And by agonist-based, I mean prescription psychostimulants, so similar drugs in their pharmacological action to the drugs of abuse. So just to give a brief overview, we have a scarcity of evidence-based options for the treatment of stimulant use disorders in general, not just methamphetamine, but also cocaine. The best available evidence we have to date comes from psychosocial interventions, and I would name continuous management as the top intervention in terms of the robustness and the efficacy for this kind of condition. In terms of medication, we're a little bit behind, so we don't have any medication currently approved to treat stimulant use disorders, including, again, both cocaine and meth, by the American FDA, by Health Canada, and by the Brazilian regulatory agency either. And I would say at least from most of the European regulatory agencies as well. But we do have, come from systematic reviews, promising alternatives in terms of pharmacology, which would include naltrexone and topiramate for methamphetamine, and bupropion, topiramate, and prescription amphetamines for cocaine. This slide is just to show you that we have 2 systematic reviews from Cochrane, one of them on cocaine and one of them on meth, evaluating the efficacy and safety of prescription psychostimulants. So they included a wide array of psychostimulants. So they included prescription amphetamines, they included modafinil, methylphenidate, bupropion, selegiline, and others. And they found different results in terms of efficacy. The systematic review for cocaine found significant results to promote sustained abstinence by the prescription stimulants, especially with amphetamines and bupropion. So they already found some evidence supporting the efficacy in 2016, whereas the methamphetamine review, which was from 2013, did not find any significant results. So the results were a little bit more discouraging, but we're going to dive into this a little bit later in this presentation. So this is important to mention that for safety outcomes, they did not find any statistically significant difference in terms of adverse events in general, serious adverse events, so that would lead to death or hospitalization, and cardiovascular events in both reviews, both for when treating patients with methamphetamine dependence and cocaine dependence with prescription psychostimulants. They did not find any difference in safety outcomes. This is important to mention because safety is a very common concern by prescribers. So these results here, which are underlined here, are encouraging. So we published this systematic review with meta-analysis in 2020, and I'm going to present the results to you now. So unlike the Cochrane reviews, we chose to restrict our analysis to just prescription amphetamines, methylphenidate, and modafinil because of their dopaminergic potency. So we did not include bupropion, for example, which is a drug that has a psychostimulant effect as well. And that had a significant body of studies. And we did assess stimulant use disorders in general, so including cocaine and methamphetamine. So there were 38 clinical trials included with a total sample of 2,889 patients. We looked at 3 outcomes of interest. So the primary outcome, which I'm going to show you the figures about, is sustained abstinence, so 2 to 3 weeks, mostly 3 weeks, most of the studies. Drug use, which would be the percentage of negative urine tests throughout the study, and retention to treatment, proportion of completers among people enrolled. So, and the quality of evidence was evaluated using the GRADE tool. So this is the first figure I want to show you. We do have in the red circle the overall measure of effect. So for those who are not familiar with meta-analysis, we don't want the diamond here to touch the line. So the right favors it shows an effect favoring psychostimulants, and the left would favor placebo. So as we can see, if we put the results all together, we do have a statistically significant effect of 1.45, which means that the desired outcome would be obtained 45% more for people who use the medication compared to those using placebo. But this is a general measure, including meth and cocaine studies. So it's more interesting to look at each of those separately. So as we can see, the statistical significance of these results in the bottom come mostly from cocaine studies. So we do not have as many methamphetamine studies as we have cocaine studies, but we can see that the 3 of them are consistently statistically not significant. So we can see that the results are pretty similar. But this is not 100% bad news. I'm going to discuss this in the following slide. So this slide brings the same overall measure, but this time we'll divide those not by the drug of abuse, but by the medication. So we have prescription amphetamines, modafinil, and methylphenidate. Methylphenidate and modafinil, as you can see, were not statistically significant in terms of promoting abstinence, but prescription amphetamines definitely were. So we did find a measure of 2.44 in terms of risk ratio compared to 1.22 and 0.90 for the other drugs, and they were not statistically significant, whereas prescription amphetamines is way far from the bar. This is good news, and this could represent that prescription amphetamines are superior to the other stimulants in terms of efficacy, but there is something that is noteworthy and that gives us a little bit more hope for the methamphetamine studies. All these studies conducted with prescription amphetamines were run on cocaine use disorders. So all of these studies, Grabowski 2004, 11, 2015, and so forth, they are studies looking at cocaine use disorder. None of them looks at methamphetamine use disorder using prescription amphetamines. So there is still hope, and I know that we have a very interesting trial that is going to be presented shortly. But there is still room for more research here to find out if those drugs that seem to be efficient for cocaine are also effective for methamphetamine use disorder. So that's why I included this balloon. This is very important to mention. So just to show the limitations of our study, we did have a limitation on blinding because both blinding of participants and outcomes is difficult when you have a drug that has a strong behavioral effect. So if a patient is taking a high dose of amphetamines, it's likely that they will notice an effect, or maybe the clinician or the person who is assessing the outcomes might notice as well. So we decided to put everybody as unclear. And as you all know, we have a big problem with attrition, so high dropout rates for clients with substance use disorders. So this was a very serious limitation of our studies, and most of the clinical trials that we included in the systematic review had high dropout rates. So the main finding was that prescription amphetamines are efficacious for treating cocaine use disorder. And we did find evidence for the following outcomes. So promotion of abstinence, which is what I already showed you, reduced use throughout the studies, and end of study abstinence, which is very promising and compelling. We did find better results for higher doses and extended release formulations of prescription amphetamines mostly. We still don't know about the effect of prescription amphetamines for methamphetamine use disorders. So I know that Dr. Badness will present his trial, and I know that there are other trials being run in other countries such as Canada and Australia. So this is a question that we're soon to answer. We're hopeful that we'll have more compelling results in the future. And that behavioral effects of medication and high attrition compromise the quality of the evidence from the beginning, unfortunately. So this was my presentation. Thank you all for coming. And this is my email address if anybody wants to reach out. Thank you.
Thank you very much, Victor. That was very interesting. And I think that's a bit also something we have in our session. In the title, we talk about stimulants, even though we are probably in this webinar and in the previous one focusing a bit more on methamphetamine than on general stimulants. But this is probably one of the challenges to disentangle responses that have to be tailored specifically to methamphetamine or that have not to be, and what the adequate outcomes and determinants are surrounding the different uses and the different patterns of use. So said that, I would love to invite Lars to introduce us to the Atlas for Dependence work. The floor is yours.
Thank you very much. So, thanks for the very nice presentation from Vitor, which was a very good introduction for this and gave a lot of the background. So this trial, Atlas for Dependence, will test agonist treatment with dexamphetamine for people with amphetamine dependence and opioid dependence, and will be a randomized controlled clinical trial. And together with my the other PIs also, so we are 3 PIs, Kjell Jansson, myself, and Fateme Chalabianlu, that and a big group that you will soon see. So and the background, in addition to what was presented from Vitor, among people with illicit amphetamine and methamphetamine use, these are 2 of the large global contributors to both cardiovascular disease, psychotic disorders, and these groups have increased mortality and reduced quality of life. And worldwide, there are approximately 34 million people with amphetamine and methamphetamine dependencies. And in Norway, they constitute between a quarter or a third to 50% of those with combined substance using and people with opioid dependence that have codependence to amphetamines. And these have very high rates of psychiatric and somatic comorbidities, homelessness, criminality, and several other risk factors. And as mentioned, there are few RCTs, especially for people with amphetamine and methamphetamine use, and a few of these that are large. There has been one with going from in Australia, the Lima study, and also one mentioned in Canada, but especially for people with opioid dependence, there is close to no evidence existing. So that was the background for our study, and our aim is to investigate the efficacy and safety of agonist treatment with prescribed dexamphetamines added to standard interventions, including psychosocial approaches and opioid agonist therapy to people with amphetamine and opioid dependencies. And this will be done as a placebo-controlled clinical trial with dosages between 30 and 120 milligram dexamphetamines daily, and we will compare a number of objectives that I will explain shortly. So, and this will be done as a multi-center trial in Norway with 2x2 trial arms in with 12 plus 12 week period. The study will be pharmaceutical independent and blinded. So in short, we will randomize participants to receive either dexamphetamine in dosage intervals between 30 and 120 milligram daily for periods of 12 weeks, and then randomized again whether to for a new 12-week period. In other words, participants will then receive either 0, 12, or 24 weeks in the two periods. And this will be conducted both in Bergen, Stavanger, Southern Norway, Kristiansand, Arendal, Vestfold, Trondheim, and Finnmark. So it will be a study comprising several of the health regions in Norway. And we will recruit approximately 200 patients from these centers, and with dependencies to both amphetamines and opioid, and receiving opioid agonist therapy. So in addition to the primary outcome, which is change in use of stimulants based on observed urine tests that will be assessed weekly, we will also assess change in psychological distress, psychosis symptoms, health-related quality of life, attention, and cognitive performance, and fatigue symptoms, in addition to treatment satisfaction and adherence to treatment. We will also assess infection-related or injection-related infections and change in criminal behavior, violence, and economical impact. So this trial will start recruiting in a few months' time, so around August this year, and will be running for approximately 2 years with recruitment and data collection. So and it will include adults with both opioid dependence and receiving opioid agonist therapy, and also amphetamine dependence for at least 3 years. So I won't say too much more about this study initially, but we will also in parallel run another study where we will also assess benzodiazepine dependencies and with substitution therapy there, and are also working with heroin assisted treatment. So but might hear more of that later. So thank you.
Thank you very much, Lars. I have to say I think it's a very, very nice point of view that you introduced now, also this idea that we all know that it's more about a polydrug use, and you are focusing much more on this integrated use of amphetamines and possible responses considering that too. That said, I think it will be very nicely complemented by what our colleagues from Czechia will be telling us. So Roman and Jakub, how are people with methamphetamine related problems currently being treated in your country? So what would you say are still open questions?
Well, thank you for passing the word to us. I'm waiting for the presentation to show up.
You cannot see it? You have already the control.
Oh. It was already said that we will talk about the Czech Republic and about the current treatment of patients with methamphetamine use disorders. We have nothing to disclose. This is also important to say. Well, there is a very short trip to history, because it's important for what we are going to say later. Well, the first backstreet synthesis of meth dates back to 1974. So this is basically 50 years of methamphetamine use in the Czech Republic. So it's a long history, and we gain a lot of experience. But it is also good to say that it is not about methamphetamine use as it is, but it's about stimulant use. And we observed also, we did some research on how many tablets were used, stimulant tablets were used in the former Czechoslovakia, and the rise. And we were able to observe sudden rise in abuse of stimulant medication. And also, what is interesting about the Czech Republic is that it is greatly used IV by the users. So, who are the patients with methamphetamine use disorders? Because we don't have much cocaine use, we don't have much amphetamine use. It's predominantly methamphetamine. Well, good thing to say, or important thing to say, is that majority are polydrug users. So we don't have many patients or users who use solely methamphetamine. Of course, there are highly the chances of acquiring some somatic or psychiatric problems in these users is very high. By the staff, because we conducted some studies looking at who they are. They are usually younger. They are described as immature, creative, impulsive, and sometimes with dissocial behavior. These all are complications in the treatment. They are more prone to be aggressive compared to other types of patients. and they have also more problems with following, or they are reported to have more problem following the rules of any type of treatment service. Very important what we observed, and basically what was the observation of Jakub in his treatment practice, was that there are two types of patients. Ones who we named steady users. These people prefer rather smaller doses, or they use methamphetamine in smaller doses, and their goal is to function well over the day. While there are binge users who usually use in runs and in waves, and they usually use huge doses of methamphetamine, but they have also periods of not using because they can't take anymore, and they have to sleep sometime. So this is one important observation we did, and we also focused on our later study. And there are also interesting periods when these people are more prone to treatment, and when they respond to treatment much better, and it is usually when they face the lack of energy during the winter period. So this is one interesting observation we did, and we also observed in our practice. And in Jakub's practice, as it comes to using methylphenidate in treating patients, usually the ratio between men and women is that, you know, there are twice as many men as women in treatment, but usually women responds to methylphenidate treatment in different ratios. So twice as many women, you know, the results are better in twice as many women as men. As it comes to treatment, as it is, there is something was already said to the speakers before us, but you know, psychological, psychosocial interventions are treatment of choice, and it is usually to alleviate some psychotic symptoms of hallucinations, and you know, having no medication is really strong argument for the search of some medication that would be really helpful in treating these types of patients. We did several studies that we wanted to use as an argumentation for our funding agencies in the Czech Republic to fund trial like in Norway. We were never successful, so I'm very happy that Norway has the chance for the whole Europe to do so. And this work was did not come in vain, because Jakub was also able to write some guidelines for treatment of methamphetamine use disorders. I will share the link through the chat, and it's available. It's very simple, but it's available in Czech, well, unfortunately, but also fortunately in English and Spanish. So I don't know what is the quality of translation, but basically you can get a good idea of what was the content. So be happy to, you know, feel free to use it. So I will share the link after I will start presenting. So the case series that we have already mentioned, you know, case series are not RCTs, of course, but these can lead us to some important information. And one of the specifics that I'm going to talk about in the few slides that come is that we also observe the specific patient characteristics. Below you can, or on the bottom, you can see the studies, so feel free to download it if you want. And so we used methylphenidate as a drug of interest. you see that the case series was it was not huge. It was 24 patients that we basically studied more thoroughly. What is important to say maybe is the starting dose was 20 milligrams, and the patient had a chance to titrate it together with a doctor, with Jakub, and the mean dose of methylphenidate, the daily dose was 37.6 milligrams. What we found, and this is what one of the outcomes, or findings, was that the most favorable outcomes were observed in the steady users, those who need to function well over the day. So out of 17 patients who profited from treatment of methylphenidate, 14 were steady users. Profited doesn't necessarily mean that they abstained. The bullet below that tells us that we had 10 abstainers, and 9 out of them were steady users. So it is just interesting in our understanding. There is an interesting patient characteristic that may also that is worth to control for in RCTs that will be run in the future, but it may be also some explaining factor to why substitution treatment may not be as effective in all types of patients. And also one good thing in terms of when to recruit for RCTs or when to treat patients is also timing of enrollment or season when the treatment is being started, for example, because these people need to see a quick effect, in my understanding. So majority of patients were enrolled during the winter period. So this is also something that can be considered as a good way how to attract patients and how to make them believe that the substitution treatment is possible, and then to stabilize them later. And then once they are in the treatment, this is something that they start believing in treatment and like the doctor and blah blah blah. So what are the open questions? This is one of the last slides. So we in the Czech Republic, we have a long history of methamphetamine use, rich experience with at least long experience with practicing treatment for methamphetamine use disorders. But we have very low evidence of how this treatment is being conducted in the Czech Republic. Unfortunately, we have very little to offer to the world. We are one of the countries that has this history, but we don't write, we don't publish on that extensively. We try to make up a little bit, but this is like self-criticism in terms of our country. So this is one thing that may trigger the discussion. The other thing is that let's not forget about some technology-aided treatment, e-health, mHealth, that show promising results in treating other substance use disorders. But to methamphetamine use, this is something that I believe can work very well. And as it comes to the Czech Republic, we are more believing in agonist pharmacotherapy, and we conducted a assessment of needs of the current drug users and their willingness to participate in randomized controlled trials. This was one of the preparatory works. And this was also something that was subjectively favored by problematic drug users to be treated with agonist drugs instead of opposed to antagonist drugs. So thank you very much. And as promised, I will be now trying to send the link to the guidelines. Thank you for your attention.
Thank you very much, Roman and Jakub. We have a few minutes time. I'm not sure if you would maybe like to show a bit or express a bit your experience, your personal experience with the application of this guideline. So maybe a bit like a case report, since we are lucky enough to have Jakub with us. I don't know if you would be able to briefly talk about this very severe cases of methamphetamine use disorders and how you handle this.
Just a moment. Řekneš něco k tomu, jak léčíš ty uživatele a na čem jsou založeny ty guideliny?
Ty guideliny jsou založeny.
I will be translating. Jakub knows English, but he just pretends that he doesn't know English.
Okay.
I have dyslexia. Ty guideliny jsou založeny na klinické zkušenosti nejen s těmihle pacientama.
The guidelines are based on the clinical practice, his clinical practice, but also clinical practice of people who treat patients in the house, but also in his other fellow psychiatrists.
A vlastně byly vytvořeny jako bezpečný návod pro to, aby to vlastně mohli aplikovat ostatní lékaři.
And the main intention was to provide some guidelines for GPs and other specialties, that mainly GPs who could get something like a safety manual on how to treat methamphetamine patients.
A já jsem je vlastně vytvářel na začátku epidemie COVID, protože jsme se obávali, že může dojít k nedostatku metamfetaminu a s tím může být spousta různých problémů.
Yeah, and the main trigger why this came into existence was that these guidelines were prepared as a reaction to COVID epidemics, and some kind of we were afraid that there will be lack of methamphetamine on the market because all the market was kind of distorted by the epidemics, but also by the overloaded other specialties. So, and we didn't know what will be the access to care. So this was to make up and to make sure that the care is available to most possible number of methamphetamine patients.
A jinak vlastně je to jednoduchý návod, který popisuje tu cílovou populaci, popisuje, kdo by vlastně ideálně to mohl dělat jako lékař.
So it basically, defines the target population, who can work with these patients, what are the requirements, what are the needs, what to possess in terms of that medical doctor.
Jak vlastně, jaká vyšetření udělat před tím vstupem do toho programu a jak metylfenidát nasazovat. A stejně tak, jaká vyšetření dělat potom, abychom to vlastně, aby jsme toho pacienta sledovali, nebo jaká vyšetření dělat při tom dlouhodobém sledování.
Yeah, and most importantly, what should be done in terms of assessing the patient when starting the care. Something about, there is a section about pharmacotherapy, methylphenidate therapy, or therapy with methylphenidate, and also what and how to do the checks while the patient is in treatment, and how frequent visits should be done, and what to do during this visit. So very simple manual.
Je to jeho první verze a já jsem přemýšlel teďka, že bychom asi ho měli se pokusit updateovat, protože přece jenom za ty 2 nebo 3 roky jsme se někam posunuli a možná, že by stálo za to některé věci udělat jinak.
And of course, this is more as a working document that would need some updates, and it was done in very short time, but it is something that should definitely receive attention and would require some additional improvements.
No, a jeden z mých motivů byl vlastně to, že jsem žádný takový manuál nenašel, žádný guideline nenašel, tak jsem si říkal, že by to mohlo být použití i ostatní. Yeah. Proto jsme to vlastně i překládali. A že by to mělo být dobře teda.
And one of the motives also was that, Jakub was trying to search what's available, and he did not find anything quickly that is at hand. So this is why it's being translated to be available to other languages or specialties or countries.
Thank you very much, Januk. That's very, very interesting. You will make the link available so that people can also look into the translated versions. Thank you very much for your contribution. And I will now give the floor to Joan Ramon Villalby, who will talk a bit about how to bridging the research and the policy and the praxis gap. So the Spanish experience. The floor is yours, Joan Ramon.
Thank you very much, ECR. Thank you very much to the European Monitoring Center and for inviting me to be part of this session. And thanks to all of you for your interest. I will try to share what is our concern. I'm working, as I said before, in the delegation of the government for the National Plan on Drugs in the Ministry of Health. And we are in part of the central administration in a country that is a quasi-federal country, where healthcare and prevention services are the responsibility of what we call autonomous communities, and we have 17 of those, and different providers are involved in different autonomous communities. Their own public services, services of local administrations, non-governmental organizations financed with public funds, and we in the central government, we are, among other aspects, responsible for surveillance, which means monitoring and reacting to new threats. And our involvement with methamphetamine derives from this role. So, first of all, methamphetamine is not like other drugs. In terms of harm potential, it's probably among the worst. The very recent paper by Bonnet in Germany ranks crack, methamphetamine, and heroin as the top harmful substances. And in our part of Europe, we've had very little methamphetamine, very little crack up to now. So we are familiar with heroin, but this is a new danger for us. This is a new threat. So we are very concerned with it. And when we see the papers from the States, that's a very recent paper in the American Journal of Public Health. That's how methamphetamine-related deaths are escalating. This is an exponential curve. An exponential curve. You go in a very short lapse of time from having a few deaths related with methamphetamine to having quite a lot of deaths. And this is increasing and it's not over. So this is explosive. So we're very concerned in a context where other people are not. And we already had an experience of an epidemic, the heroin epidemic, that came to us and we were unprepared. And this is what it was like in the 80s when heroin was killing so many people every month. So we are very concerned of this, and we think we need to move and prepare. And preparedness means we need to continue monitoring. We need to review options of what can be done. We need to inform the public. We need to improve treatment capacity, which is very small now because no professionals or almost no professionals are familiar with this treatment. And we need to explore options in risk reduction, of which we have learned a lot from heroin, but we know very little or have applied very little to stimulant drugs. And we need also to ensure the awareness of supply control officers. So that's what we are beginning to try to do. And I'm very modest because we're not bridging the gap. We're grasping to be able to not be gulped by the gap. But in summary, there's growing supply. The police has been cracking down on local production, which is the new thing. There have been some very large international traffic operations involving more than a ton coming to Spain from Mexico, to Europe from Mexico. And there's a sustained increase in seizures and the rest. Now, this is of a very small absolute magnitude. In a year, the police gets 30 kilos of crystal meth and 40 tons of cocaine. Now, for them, crystal meth is not very important. So we need to explain to them the harm potential of this drug so that they maintain some focus on methamphetamine. And we have signs of more demand than use. On one side, consumption as a stimulant to work longer hours in some settings. Among Filipino workers in Barcelona, shabu, which is how they call crystal meth, has been used just to work more. We have been having some presence in clubbing, in night venues, sometimes cutting other substances, but it's very small. That's essentially MDMA and other drugs. We have had some consumption related to chemsex, that's binging on methamphetamine over a weekend or 3 days, more frequent in Barcelona than in other cities, but with signs of spreading. And then we are very concerned with the signs of consumption with heroin in some settings, with drug users that have a long history of drug use and are in very poor condition. And then the density of metabolites in wastewater of some cities is not like in the Czech Republic or in Slovakia, but it's beginning to be similar to that of London or Amsterdam. I was checking today the results in the new bulletin of the European Monitoring Center, which were relaxing for me because there was a sign of increase over the last 12 months. So we need to act. We also have some admissions in addiction treatment network, small numbers, 100 and some over a year, which is nothing compared to what it is for cocaine or heroin or cannabis or alcohol. And there's some presence, very minority, about 20 deaths a year in acute reactions to drugs. Out of our 1,000 deaths a year, 20 showed sign of methamphetamine, which is not very much. But we began moving and we began talking to the police and intelligence officers in the CIDCO, which is like our FBI, let's say. We talked with European Monitoring Center officers. Thank you, ECR. You were always very helpful. We talked to some NIDA officers with which we have contact. We talked to Czech experts and counterparts, and I want to express a big thank you to Jakub, who was hard to reach, who was so friendly, who was so nice, who was so helpful. Thank you so much, Jakub, for all your help. But also to the official counterparts, because through the CHD, we also talked to them. The chemsex experts in large cities in Spain, especially in the city of Barcelona, they explained some of their experience in the last webinar. The addiction officers in some large cities, even if they seem not to have such a large problem. Professionals involved in harm reduction who have settings. Use of drugs is not a criminal offense in Spain. So we can manage harm reduction facilities where drug users bring their own drug and can use the drug under supervised under health supervision. And this was specially meant for heroin use, but now we have a substantial use of stimulants and not injected use. So how these professionals were dealing with this is important, and then some leading clinical professionals. And I'm happy to have seen some of them following this webinar in the list of participants. So thank you so much for all your help. Now, in terms of supply control, this is the big thing. The main substances in Spain are cannabis and cocaine, and meth seems to them a very small issue. And I said, in terms of arrest, 300 for meth, 6,000 to cocaine. In terms of seizures, 45 kilos of crystal meth, 37 tons of cocaine. So we have explained to them the risk, and they are reassessing the issue, and we intend to keep in contact with them. I think it's important because this is supply control is as important as our own work from the health perspective. In treatment perspective, as it's been said, consensus is there on contingency management, which has a very limited viability in our treatment network, which is essentially publicly financed and unlikely to be able to use contingency management. The consensus in the promise of cognitive behavioral therapy exists, and it's now the most used option. Now the retention rate is about 40%, 50% a year after beginning. So it's modest, but it's what we have for alcohol and cocaine too. It's not much worse. We don't have very clear evidence for pharmacological treatment. There are studies in process, and we hope to have that science progresses. And then there's this idea of psychostimulant substitution therapy with a harm reduction perspective, but it's just a promise that is very suggestive, and we need more studies on that. So we put together just a month ago a handful of leading experts, clinical experts from the country, and it was clear for all that there was this interest in psychostimulant substitution therapy. Many of the patients with meth presented comorbidity, and very frequently with attention deficit disorder. And there was high interest in the Czech recommendations of the Addiction Society that could be feasible in Spain. And there was interest in these dexamphetamine studies, which right now would have a much more complex pathway for prescription in our network. And then very clearly, service coordination must improve, because now these patients show in hospital emergency rooms. They are derived sometimes to mental health, sometimes to addiction services, sometimes to internal medicine, sometimes to sexually transmitted disease services. And the connections between all these services are very weak, and we have the impression that we lose our patients on the way. So for the group, we now call it the methamphetamine working group of the National Plan on Drugs. The priorities now would be first training for addiction professionals, for mental health professionals, and the key role for professional organizations. We have Sociedad Alcohol, we have the Spanish Society for Dual Disorders that can play a very important role. And I'm glad to say that they are incorporating the topic in their annual congresses. To maintain work with all different actors in diverse fields, that's our role, and we intend to play it intensively. Now, many of our professionals are not fluent in English, so we need to generate updated documents and articles in Spanish. There's very few. We've put a little section in our web, and a lot of it, the literature is in English, and we know many of our colleagues cannot use it in full. We think we need to reduce variations in care and in screening for consumption in different services, and that involves mental health and harm reductions. We would need to develop our own protocols for prescription with algorithms appropriate for different settings, which would be clinical settings, but also harm reduction settings. And we need to study and document how patients evolve. What Jakub was saying and what Roman were saying, we need to have some follow-up, even if it's not from a trial, a randomized controlled trial. We need to have series of patients that show us what happens and what can be achieved, on the dangers and the problems with these patients, especially if we use medications and if we don't use medications. And we are collecting and disseminating key information, both for citizens and professionals. We wrote a guide for the general citizens, which is in our web, because there was very little, there was very little useful information in Spanish. But we also have put together a page on treatment for methamphetamine disorder, including the clinical guides that are available from Australia, from Germany, from Canada, recent papers, including Vitor's papers, and harm reduction practice, including our translation of the Czech, which is a bit different from yours, Jakub, but we're a bit happier with our translation. But it's your document and the link to your own page. And we have had webinars like this, trying to involve the leading professionals and the different parties. They are recorded there in our website. And that's all. So in fact, it's very modest. I hope you can find it more or less inspiring, but it's collective work in progress. We learn every day, and essentially we try to develop things so that if methamphetamine expands, it doesn't take us unprepared. And if any of you is fluent in Spanish, you have a link here that can be useful. Thank you.
Thank you very much, Jean Ramon. I honestly think this is not modest. This is inspiring, as you say. I like a lot the integration of different information and the way to try to progress with all this information and evidence and sometimes pure experience to try to move forward and to come up with something new and better. And the collaborative effort, I think, also between different countries and in Europe and internationally is inspiring. I do like it very much. And I think that's probably the moment where we can give the floor to our auditors and hear what they have to ask.
Yes, we have a few questions on the questions and answers. If you don't mind, I would like to read them. So the first one is by Esther. First of all, thank you to Victor for the presentation. A question regarding substances. Did the cocaine studies only contain cocaine hydrochloride use powder or also crack use? Victor, is for you for your systematic review.
So I provided an answer in the Q&A box, but
it's interesting for everybody, I think.
Of course.
Yeah.
We did not exclude any studies on crack or even base or cocaine base. But the vast majority of the studies was on powder cocaine. So virtually all of them.
Okay, thank you very much. Another question is for Lars. The inclusion criteria about 4 days of use in the past months, is it based on self-report or any urine testing is involved? And then another question, will you supervise dexamphetamine intake? In other words, is there a possibility for patients not to take the medicine and sell it instead of, for example? Lars, for you.
Yeah, thank you for the questions. For the first one, it will be mostly based on self-report, but mostly they will also have at least one with urine test confirmed use. So, but the frequency is based on self-report relating to the dexamphetamine intake. So it will mostly be intake twice daily, and that will be during delivery or the follow-up visits that will be weekly. They will be it will be observed intake, while the other intakes will likely be done with electronically guided device that will deliver it with intervals. However, it cannot avoid the possibility of people selling them for diversion. So, but at least it can prevent the intervals or most of the tablets to be taken simultaneously. So,
Okay.
but yeah.
So you keep a certain level of control to make sure your results are the results of your intervention. Another question always by Konstantin to Roman and Jakub. Your program is long-standing. Do you have information on how many patients have been treated to date in your program and in Czech Republic in general? Is there any unofficial report, ideally with some outcome data?
Well, the most simple answer is that you can go to our Czech National Drug Report that is published in English, also on the EMCDDA website, and there are yearly statistics of how many problematic drug users we estimate there are, how many patients are treated in what type of service. So we have outpatient, inpatient therapeutic communities, and also some after treatment programs. So you can find exact figures there related to specific types of drugs, so including methamphetamine. So this is one of the answer. The other answer, as it comes to our treatment facility, this is more question to Jakub, but we have inpatient wards where we treat mainly alcohol and alcohol use disorder, and also people who use medications. We have very little patients who are treated inpatient with methamphetamine use disorder. But as it comes to outpatient, this is more question to Jakub. So kolik má pacientů v tom, kdy třeba ty jich máš v ambulanci? Kolik substitucí?
Jako substituci?
No, obecně substituci.
Já myslím, že obecně jich můžu mít tak, čítám jako 50 až 100.
So usually it depends and it varies. Usually the average is 75 patients, but 50 to 100 patients who are in actual care with Jakub only as an outpatient. And who use substitution? There are it's more individuals because it's usually off-label and it's not regular treatment that is being delivered. So as for now, currently 5 people who were treated with off-label methylphenidate.
Okay. Thank you very much. An example of practice, as we said before. It's very interesting to have this exchange here, and thank you to Konstantin for his very interesting questions. Another question to Roman and Jakub concerning prevention. In the USA, in at least some high school, the police visit school and present some of the drugs, giving the presentation of their influence and consequence. Do you know about it happening in some of the schools in Europe? This is more about prevention.
Yeah. Okay. As I guess that every country in the world can come with some examples of good practice, but also bad practice. In the Czech Republic, we definitely have many cases that we could present as it comes to bad practice. I would not consider showing and providing information and showing how drugs look like to children. This is important for them to know. The question is, if this is the only thing that they do with children, it is not very helpful. We need to tell children what to do instead. We need to show them positive examples of how they can spend their free time, how they can improve their social skills, and how they can make up for some psychosocial things that they don't possess and they need to know. So, for example, how to fight being alone, or how to take care, how to
emotional intelligence.
Thank you.
Yes. I thank you very much for this answer, because it also is a bridge to a next webinar we will do. We are organizing with Alessandra, exactly talking about substance and prevention for young people. That is a very delicate point everybody's interested in. And there is another question by Alexander asking if the EMCDDA currently supporting studies on the subject. If you mention, Alexander, studies like clinical studies, At the moment, we don't have funds to support this type of tasks. What we know, what we do is to collect evidence. So it is really the work of Alessandra, collecting research studies and then synthesizing them, for example, in our best practice portal, to try to accompany the new development and let them known by our audience. So I don't think we have other questions for this moment. I wonder whether anybody of you would like to share or make another comment. ECR, I'm not taking over your role. There were some points. I'm not able to do conclusions. I'm not the director, but I really liked the way you presented, for example, the value of the European collaboration, where we really can use the experience of different countries to grow together the knowledge we need. And also I liked very much the way you presented the synthesis of the available evidence, the new evidence that is being created, how the practice try to integrate all this experience. I think it's really also nice overview on how we can use the evidence all together to work towards an improvement for our clients and for our problems. But ECR, I don't know if you want to invite our speakers to give a comment.
So thank you, Marika. We do have a bit of time, and I was wondering if each of you would like to have one formal conclusion on this. I certainly do have one, and I think I almost pointed already towards it. I do think we are in exploration of this topic. It's a moment where we all have little bits contributing to the bigger picture, and I hope this webinar is kind of the beginning of putting it together and trying to integrate it. And as Ramon said, to be inspired and get it into something that really moves the whole thing forward. But I would really invite you, each of you, if you would like to have just a conclusion sentence. Maybe Victor, who want to start as the first?
Well, I think it was very nicely put in how the presentations complement each other. I think that it was a nice collective effort, and I think the word to summarize it all is hope. I think this is a very challenging condition, and we do have a huge difficulty ahead of us. But joining efforts from many parts of Europe and the world, I think we stand a chance, and there is hope, and the hope is on research, and so we need to disseminate this topic more to be able to have access to funding, because this is a very important public health problem. But we do have ideas and promising ideas that with a little bit more research can be better shaped into action. So I think the word for this seminar is hope.
Thank you, Victor. I hear that. Lars, do you have some final remarks, maybe?
I will just support the very wise and nicely concluded remarks of Victor, so I don't have anything additional to add. Thank you for this nice webinar.
Thanks. Roman?
Well, I wanted to thank the organizers for this type of meetings. It is very important. We briefly discussed what we could say as a closing remark, and we discovered that the search for the holy grail of methamphetamine treatment goes on at least for 15 years, maybe longer. And I guess that Europe is a little bit behind the US, Australia, New Zealand, and we can make up. And I'm very happy that we know about these trials that were conducted, are going on in Europe and will be conducted in Europe. So we are happy that the holy grail is a little bit closer to us. The other question is if it will work. but we hope that we will be able to provide some type of treatment, pharmacotherapy treatment, or pharmacotherapy to our patients, hopefully soon. Thank you, and good luck.
Hope again. Joan Ramon, do you want to have a final remark?
Well, first of all, a big thank you, and then as it's been said, this is a network in our field. It's a small field within the health and social services, but and the epidemiology services. But we are a network of very committed people, and it's great to see that. And we are also committed to help each other, and that's important and that's valuable. And the European Monitoring Center can act as a catalyst for many of these contacts and initiatives. And the other side is that we need more studies, we need more science, but we would be guilty if we don't try to apply what we already know, even if it's not totally conclusive. Because as in many fields, we have knowledge to do things, and so we need to move, because the drug market is not quiet. It's changing all the time, and stimulant drugs are the new epidemic, visibly, and methamphetamine and perhaps crack are real threats for many parts of Europe that were free of them until very recent.
I totally agree. I couldn't agree more. Thank you all for being here, for your contributions. And Marika, I pass it to you to close.
No, I cannot add anything to what Juan Ramon said. It was a perfect conclusion. The only thing, everybody in the chat is asking for your slides. So Alessandra will contact you to know if we can share them. For everybody, the registration, the recording of the webinar will be available in the next days in our website. And we really thank you. Also, because you shared also a lot of materials in the chat. So we will compile these materials and we will make them available for the participants, because I think it's really building all the knowledge through these kind of contributions. I don't have anything else to add. We will share information on our next webinar, and really thank you. Heartfelt thank you to all of you.